Hello everyone. Today we'll be talking about an important trial recently published in New England Journal of Medicine. That is Summit trial study. So this Summit trial study, what is it wants to show is that they have tried to see the role of tirzepatide for heart failure with preserved ejection fraction. So what they have done is basically they have taken patients of heart failure with preserved ejection fraction with obesity. So HFpEF, which is defined as ejection fraction of more than 50%, patient with heart failure with ejection fraction of more than 50%, and obesity patient, that is BMI of more than 30. So both this patient they have taken and they have given this tirzepatide drug, which is a GLP-1 agonist and also a GIP agonist. So we'll discuss it one by one. So this trial they have wanted to see that how are the outcomes of heart failure with preserved ejection fraction in this space of patients. So as we all know that obesity increases the heart failure with preserved ejection fraction risk. How does it does is that obesity is a state of inflammation. So obesity itself leads to a lot of inflammation, and this inflammatory markers whichever are there, they can directly damage the myocardium and can lead to heart failure. GLP-1 agonist has been shown to have a various benefits in heart failure. So now we have tried, that is what is the GLP-1 agonist, which you are all aware of, is semaglutide. Now, what they have tried to see is they have tried to see it in the tirzepatide, that is a dual agonist. That is, semaglutide is only a GLP-1 agonist, whereas the tirzepatide is dual agonist, that is glucose-dependent insulinotropic polypeptide and glucagon-like peptide agonist. So both are there. That is what it is makes it differentiate from the semaglutide. So it has both glucose-dependent, that is GIP-1 receptors, and GLP-1 receptors. Tirzepatide acts at there. So what is the actions of that? So suppose it stimulates the GLP-1. GLP-1 does what does it does is that stimulation of this receptor makes the increase in insulin secretion. So more insulin, what will happen is it will decrease the glucose. Also it decreases the glucagon release. What does it also does is that it decreases gastric emptying. It decreases gastric emptying. So suppose the gastric emptying is delayed, what will happen is that most of the food will stay in the stomach for larger amount of time, and thus the satiety will be decreased. Because the food is not able to empty from the stomach, most of the food will stay here. So delays gastric emptying will increase the satiety. Also, it directly reduces appetite via central nervous system effect. So directly it goes and act near the central nervous system and decreases the appetite. So all this thing, decreasing appetite, delaying gastric emptying, also it has anti-inflammatory effect over the vasculature and myocardium. And thus it is also found to have some reduction in blood pressures as well. By activating GIP-1, that is glucose dependent insulinotropic protein receptor activation, it enhances GLP-1 mediated insulin release. So this activation enhances further mediation of the GLP-1, promotes lipid metabolism and fat utilization, increases energy expenditure, and modulates the inflammation. So we can see here all the effects of the GIP-1 and the GLP-1. Study design, the study which that is the Summit trial, what they have done is it was an international study. It was a double blind study. 731 patients were taken, out of which they have heart failure with preserved ejection fraction and BMI of more than 30. So they have tried to see tirzepatide versus placebo. So all the patients received the routine treatment for the heart failure, that is heart failure with preserved ejection fraction, patient who was receiving the treatment. And other than that, they have half of the patient they have given tirzepatide and half of the patient they have given placebo. And study period was actually for 2 years of follow-up. 2 years follow-up they have tried to see. So primary endpoints what they tried to measure was cardiovascular death. So number of patients who are undergoing cardiovascular deaths in 2 years, or patients admitting with worsening heart failure. Suppose patient is needing admission for hospitalization, admission for heart failure, or requiring emergency visit and intravenous diuretic injection, or patient needing the need of increase in the dose of oral diuretic. So all these criteria were taken as the worsening heart failure. So worsening heart failure was taken as patient requiring hospitalization, needing an IV therapy in an urgent care setting, intensification, that is increase in oral diuretic therapy. Secondary endpoints for weight loss, 6-minute walk distance, CRP level, NT-proBNP changes, and blood pressure. So 731 adults were taken chronic heart failure, either should be in NYHA 2 to 4, preserved ejection fraction, that is EF of more than 50, and BMI of more than 30 is obesity. So inclusion criteria, again, patient should be more than 40 years, class 2 to 4 heart failure, EF more than 50%, BMI of 30, 6-minute walk distance of 100 to 25. That means there is some limitations of the physical activity as well. And we have this questionnaire, that is consensus city case scenario questionnaire, basically for the quality of life. This looks at the quality of life. The score is between 0 to 100. And the score should be actually less than 80, and patient should have a elevated NT-proBNP or left atrial enlargement, because to label the patient as heart failure with preserved ejection fraction. Also, patient should have a recent heart failure hospitalization within the last 12 months. So any one admission should be there. So that was the criteria for them. Exclusion criteria, they have removed all the patients who have EF of less than 50, any patient having a recent MI within the last 3 months, severe CKD, prior GLP-1 or GIP agonist use, if patient is there, or patient have undergone bariatric surgery in the last 12 months, history of pancreatitis, pregnancy, breastfeeding, all these patients were excluded from the study. So baseline characteristics were matched in both the groups. Mean age of the population was around 65 in both of the patients. The majority of patients were females with a BMI of 38, and ejection fraction was within the preserved ejection fraction range. It was matched throughout in that case. So also many of the patient recent hospitalization was seen in 47% and 46.9% here. So treatment protocol was patient half of the patient received tirzepatide up to dose of 15 mg per week, and every 4-week dose was could have been escalated. So primary outcomes was what they have tried to see, it was cardiovascular disease or worsening heart failure. So they have tried to see each of this component, and when they see individually, patient with who received tirzepatide was found to have a worsening heart failure events was very less. So see, you can only 8% of the patient actually required the need of admission or increase in dose of the diuretic or IV diuretics was required only in the 8% versus 14.2% in the placebo, and it was found to be statistically significant. That is, p-value is less than 0.05. However, when they try to see only about the cardiovascular death, so cardiovascular death was not significant. It was similar in both the patients. So although slightly higher was there in tirzepatide, but it was not found to be statistically significant. And heart failure hospitalization was frequently more in patients with who received placebo when compared to tirzepatide. So you can see here also death from cardiovascular cause or a worsening heart failure events was lower in tirzepatide. And this is Kansas City cardiomyopathy questionnaire, which was found to be uh, significantly high in a tirzepatide patient versus the placebo patient. That means that quality of life was also significantly improved in tirzepatide group versus placebo group. So you can see here quality of life, 6-minute walk distance also improved, and which was all statistically significant. Significant weight loss was there. CRP reduction was also significant. NT-proBNP was not much changes was not seen here. So it shows that majority of action of the tirzepatide is not dependent upon the NT-proBNP, but it acts independent to that. And basically, its role is basically because of the anti-inflammation. So safety and adverse events, the only side effects which was found with tirzepatide was GI side effects, which was seen in 6.3% of the patient. However, there was no increase in any serious adverse events. This coming to discussion, this study showed that there was a significant reduction in heart failure events and improvements in the quality of life. Weight loss was greater. There is around minus 13.9% was seen. Unlike previous trials, anti-proBNP changes was not significant, suggesting that a different mechanism of benefit was there. So comparison with semaglutide, which is a GLP-1 agonist, which was seen in 2 studies, that is STEP HFpF trial, where semaglutide improved the heart failure with preservation fraction symptoms, also weight loss and exercise capacity. Other trials was SELECT trial, which showed the semaglutide reduced CV events in obese patients, but the effect on heart failure outcome was not explicitly studied. So comparison wise, STEP HF trial showed 8 to 9% weight loss, similar improvements in the HFPF outcomes. Similar outcomes was there here. So what could be the potential mechanisms of tirzepatide is one is the cardiovascular effects, which was basically because of the weight loss. Weight loss will do is reduces the cardiac workload and inflammation, also improves the endothelial function, enhances vascular compliance, reduce epicardial adipose tissues, lowers the myocardial stiffness, suppresses systemic inflammation, which reduces CRP. So all this thing, also a mild reduction in BP and modest heart rate increase was seen. So all these were the mechanisms which was there for the tirzepatide. Limitation of the study was limited to the obese population. It has not taken patient with HF, PEF, with EF, that is with BMI of less than 30. And also the short follow-up, only for 2 years outcome was seen. The longer outcomes could have been even better, or longer studies are required actually to see the long-term outcomes of this drug. And also a limitation was seen that in when we see the comparison of tirzepatide with placebo, CV mortality was found to be similar in both the patients. So there was no much mortality benefit was seen in this drug. GI side effects were slightly higher when compared to the placebo. Also, there was a limited data on the HFPF subgroups. So they did not mention about in heart failure with preserved ejection function what was the etiology. That is because of the renal function, renal dysfunction, or atrial fibrillation. So this subclassification was not done. And only mild SVP reduction was seen, but slight heart rate increase, that is 3 beats per minute, was seen. And trial population predominantly was Western. It was cannot be applied to what is called as Asian and African population. So on conclusion, tirzepatide demonstrated significant benefits in weight loss, heart failure event reduction, and quality of life improvement was definitely seen. However, its long-term cardiovascular mortality impact was still not seen, and we need a further investigation is required in terms of monitoring its effect in CV mortality. Thank you.